pandemic period.
Thank you, Mukesh. I hope everybody is able to listen to me.
Yes, loud and clear.
I'll be talking about surgeries in this Chinese virus, pandemic 2020. I call it a Chinese virus, not the coronavirus.
Yes. Still
Okay.
Chinese only?
Why? Pardon?
Still only Chinese?
Chinese only, yeah. Spanish flu, 1918, Spanish. It started from Spain, so it was Spanish flu. 2020, the pandemic started from China, Chinese flu or Chinese virus.
Okay.
First of all, why are we worried? We are surgeons, we are the lions of our field. We have faced HIV positive and HIV positive patients. Don't tell me none of you have operated in HIV positive or HIV positive. You are operating. We also operate in times of swine flu, avian flu, and dengue. So this is just one more virus. What it requires as compared to the other viruses, more precautions, better care, more financial burden, which of course will be reflected onto the patient, and more efforts naturally on our part. But maybe the reasons that we are worried about, there's no proper guidelines, but I must not say that because last IJ issue has given extensive guidelines very clearly. And yes, medical legal issues, it's always unclear, it's going to remain so. Now, pre-op, we have been doing our routine pre-op. So what are the differences that we are going to face? One is patient data. We are never used to get full patient data. But now with this coronavirus, we will be having to keep better data. Has already been clarified by Akash and Himal. And another thing that is counseling. In case of counseling, the only thing that we can do is increase our paper load. That is, ask them to give a consent, I might get a coronavirus over here or anywhere, etc., etc. That's the only difference that I find in our pre-op. Okay. Now, regarding the investigation, as a routine, we have been doing certain laboratory investigation. This is other than the ophthalmic investigation that we do naturally. But there are certain investigations we do in some patients, like ECG, X-ray chest, and physician review. But there are some other investigations which are required. One is that we have to ask for the history of COVID exposure, travel, sore throat, fever, cough, difficulty in breathing, etc. Or whether they have been exposed to, say, a patient who has been in contact with, persons who have been in contact with a corona positive patient. But another thing that recently I read was only just today morning I read that if you take pulse oximeter, if the patient is really moribund, he is having corona positive, the pulse oximeter will show a very low oxygenation, less than 90. Normal should be around 94 to 100 for us, for a normal person. But a fully functional but corona positive patient will have a pulse oximeter showing his oxygen saturation less than 90, maybe even up to 50, which we call it functional hypoxia. And these are the patients who naturally they've come to us, they're not going to have been tested. But if you see a patient whose pulse oximeter is showing less than 90 and otherwise is fully functional, then there is a possibility that he might be suffering from corona, and he already might be having pneumonitis, which can be tested by a CT scan. Unfortunately, CT chest is the best investigation for pneumonia in case of corona. X-ray chest may or may not be positive, but CT chest is extremely sensitive for that. So maybe a testing for the corona, that is serum coronavirus antigen antibody, whatever we test for this PCR reaction, whatever we test, plus with a routine CT chest and a pulse oximeter test might become the norm in the future. Now, in case of pre-operative, there will be dilemma of 4. COVID positive, if confirmed patient is there, of course, you will prefer not to operate, prefer to delay, or in case it is required, you prefer to operate it in a full multi-speciality hospital where the patient can be taken care of in case there are any problems. Corona suspects, again the same thing, either you confirm it that whether the patient is corona positive or negative, and then you consider for doing the surgery. Now, if there is a patient who is corona-free, you've asked the history and everything is negative, otherwise he does not have any problem. Now, that's where the dilemma comes, whether you will operate them as a routine patient or a COVID-positive patient. And corona negative, confirmed the patient has the report that is corona negative, then you are not worried about that. But if you see in most of the cases, you would prefer to take full precautions. So just like operating an HIV positive patient where we take majority of precautions. In these cases also we should take all the precautions. There is only 25% patients, that is 1/4 of the patients who are corona negative, they can be confirmed. But we have seen patients who are corona negative, I mean COVID negative, become COVID positive at a later on date. So again, for me, I think I would consider all of them as COVID positive and treat them as COVID positive and go ahead with my surgeries that way. Now, operative care, all the in case, because now when we are in a corona, I mean Chinese virus pandemic, we have to take all the surgeries, we have to consider all the patients as being positive. So all the there are certain guidelines that they give. These are guidelines I've taken from the AIOS, that IGO journal, the latest copy that we received yesterday. All the surgeries have to be a day care surgery. Most of the surgeries are done day care, but there are a few wherein the patient has to be kept in, but it's preferable not to do it, or it is preferable to start such surgeries early in the morning and get the patient out of the hospital by the evening. If there is COVID, as I said earlier, if this COVID positive is to be operated elsewhere in specialized setup, again COVID-19 suspects, you confirm and then do as a backup. Prefer to avoid off-hour surgeries. Generally, we operate in the daytime so that by the evening, the cleaning procedure, which is going to be pretty long, can be taken care of. We prefer to reduce the large surgical load. If you're doing 10 surgeries, we prefer to do 5 surgeries, giving sufficient time to each and every patient, giving due time to the patient and giving due time to the surgical aspects of it. We would prefer to separate surgeries completely. Suppose you have done one surgery, right? And before you take the second surgery, the whole operation theater should be re-sterilized. All the whatever disposables, etc., you use should be got rid of, and a whole new setup should be prepared for the next. That will take about 20 to 30 minutes. So, ideally, all surgeries should be separated by at least 20 to 30 minutes. Mukesh?
Yes.
Okay. Nobody's saying anything, so I thought maybe I'm talking to myself.
No. Go ahead.
Hannah,
Please.
Now you're too short time for a big topic, believe me. Okay.
Yes.
We prefer to do rapid surgeries by senior experienced surgeons. We want to spend as less time as possible with the patient. We prefer to reduce the operating room personnel, reduce the operation room in and out movement, so there is least turbulence in case, because this is an aerosol driven virus. Now, we prefer to, and this is something that we discussed earlier, increase the fresh circulation with minimum turbulence. What they say is if you are having either a split AC or window AC, you open the exhaust aspect of it or you open the windows. So I do not have much experience with the operation room environment control system, but there must be some setting in which you can increase the fresh air exchanges inside the OT. They also, I think they also recommended not to use positive pressure also. That increases the chances of aerosol spread. We prefer to use the least amount of drugs, least amount of contact with the patient. So we prefer to use topical anesthesia or local anesthesia and local anesthesia or general anesthesia. Even in general anesthesia, if you can go for a short GA over intubation, it's better. As such, we take universal precaution nowadays with each and every patient. In this case, the extra thing is aerosol protection. That is, for the surgeon or the person who's going to be close to the surgeon, you use a full PPE with or you can use, they have not demanded full PPE in all the patients, but they have demanded N95 mask, face shields, and clear protective glasses, double gloves. And you can use a clear plastic box as a shield between the patient and the surgeon. That I think Dr. Jethani has talked about it once earlier. They put a clear plastic sheet in the microscope so that between the surgeon's head and the patient's head there is one plastic shield. I think he'll tell you about it. Post-op, it has to be as such, it is routine, but what we have to consider is the effect of steroids. The steroids, when they put in the eyes, these steroids are going to track down into the pharynx and they are going to have local steroidal effects over there, reducing the local chances of patient getting coronavirus again because the local immunity is reduced. So we have to prefer to reduce the steroid use. Say maybe first week you give steroid and then convert them over to a NSAID like bromfenic or nepacemate, right? And systemically they do not prefer to give anything else in an NSAID except paracetamol. That has to be kept in mind. No ibuprofen, as I said earlier. And we prefer to reduce the post-op visits and prefer telemedicine. Telemedicine would be helpful in this case because a major part of the work has been done. You know the patient very well. And what is required is the patient to tell you this episode, maybe a 5-minute consultation on the telephone would be sufficient to satisfy yourself. And now the patient is fine. You just advise him regarding how to take care of himself and what medication changes are to be done. Or you could already explain to them earlier, just reinforce it. You can do maybe even a video call on a WhatsApp. It's all acceptable. Now, these are the resources that I basically used. Initially I found it in IC Ophthalmic, International Council of Ophthalmology. It's good. They've got a whole range of guidelines from everywhere. But the best one I found was the latest issue of IGO, that is IGO 2020, volume 96, issue 5. It's a very good issue.
Thank you.
Thank you very much for your patient hearing.
Yeah, thank you, Arshad. Dr. Ketan had a question.
Harshal?
Yes, sir.
Hello. Harshal?
Yes, sir, I can listen.
Hello?
Yes,
sir, I'm listening, sir.
Yeah, Harshal, good information you have shared with us. I have one question regarding the SpO2 less than 90. See, I have the talk with some of the physicians. The patient who is COVID-19 positive, they have some symptoms, but their SpO2 is less than 90, then they admit the patient in the ICU or on the ventilator. But if
that's absolutely right, sir.
If it is more than 90, they don't do anything. So plus 90, maybe SpO2 will be there, even if the COVID positive patient also.
That's correct, sir. There is a whole set of patients that we can say that, but there is one set of patients in which the only thing that we find is the pulse oximeter showing less than 90 saturation. These are the patients who have functional hypoxia. They are fully functional. They don't even have sore throat or a fever or anything. Or they've had it, but they've neglected to mention it, or they've neglected, already conveniently forgotten it. But if you see a pulse oximeter with less oxygenation, patient fully functional, you can suspect pneumonia and you can get a XHS or CT done, or you can send them to your physician friend just for confirmation. Suppose by chance it does not come out, that's fine. There's nothing wrong with it. But suppose they find maybe the physician will be able to save his life.
Yes. Low SpO2 is a risk. You have to take care of it. Definitely.
I think CT chest, if it is possible, or XHS with pulse oximeter will be a very good guideline for taking care of these kind of patients.
Yes. Now, for the lack of time, we'll move on to the next question, next presentation by Dr. Jitendra Jethani. Then we'll